Good evening, everyone. And again, welcome. We're delighted to have you here this evening. It's my privilege and honor this evening to introduce to you our speaker, Dr. Mary Todd Gray, a colleague and a friend. Dr. Gray earned her Bachelor of Science degree in nursing from the University of Michigan. Dr. Gray then relocated to New York City, where she attended New York University, earned a Master's of Arts degree in biophysical pathology and nursing, and a PhD degree in research and theory development in nursing science. Dr. Gray's professional career has included 49 years in nursing education, of which 32 years was spent in the PASHE system, both at Bloomsburg University and here at ESU until her retirement this past June. She also served as a faculty research liaison at the Lehigh Valley Healthcare System Pocono Division. While a faculty member, Dr. Gray was extensively involved in service to the university and the community, especially in promoting student research activities. Dr. Gray's scholarship activities are extensive and include presentations locally, nationally, and internationally, articles, book chapters, and reviews on topics in nursing education, advanced directives, substance abuse, mental health nursing, and ethics. She has published her theoretical insights and research findings in highly esteemed referred nursing journals, such as the Journal of Nursing Philosophy, Nursing Education and Practice, Archives of Psychiatric Nursing, and the Journal of International Nursing Education, and that's just to name a few. Today's presentation is currently in progress also for publication. Even after retirement, Dr. Gray continues to pursue active research in the broad area of addiction and substance use disorders from a holistic perspective in nursing. Dr. Gray's presentation today is timely and fascinating. And you can see her title up there because it's been an evolving title for her publication. I'd like to say the format for this evening includes the presentation, followed by a question and answer period. However, Dr. Gray suggests that if you have any questions throughout her presentation, please feel free to ask them at any time. So now let's give a warm ESU welcome to Dr. Gray.
Thank you, Dr. Bruno, and can you hear me?
Yes.
Oh, good, okay. And Dr. Perangeli, I appreciate it, and I certainly appreciate all of you coming to hear about my research study, which I'm quite excited about, and I can tell you I've spent a lot of time on it, but that's the nature of research, which students can attest to who've already taken the research course. So this is my latest, and I have basically finished my manuscript to submit to publication, but it is not quite there yet because I'm waiting for your feedback tonight to give me more insights that I might have missed or maybe need to clarify. So I'm so glad you're all here, and you get the first chance. So, okay, now. Move on. I'm sorry, I'm just learning this. Okay. The first thing I wanted to do was explain a little bit more about the community on the fringe, because it is a cultural metaphor that I have chosen. So any of you in the English department might have some question about how I'm using the word metaphor, and of course I'm using it in terms of my own interpretation as a representation of my findings from this study. So I just wanted to clarify that. Basically, a metaphor is used in place of, to refer to another. It's an explanation to refer to, in a concise form, to refer to something else. And the fringe part is based on my idea of a shawl. And it just so happens that I have two shawls here. One given to me by my daughter-in-law, as you can see. This is from my daughter-in-law. I won't tell you whether it's my favorite daughter-in-law or my one that is not quite my favorite, and that you can surmise for yourself. And this one given to me by one of my dear former faculty colleagues who also retired this year. And I think she got this in Egypt. Well, and during her travels. That's Dr. Patty Hannon, some of you may know. But what I want to point out about the Fringe, that you all, some of you may have a shawl, it is connected and made from the, connected and made from, is this on? Yeah. Connected and made from the material of the shawl, but it extends beyond the shawl, and it's made of the same material, but it has loose ends. It flutters around, and it can actually have a different interpretation. It's kind of a come hither, depending on how it's used. It extends into space beyond the material itself, and it speaks to something more than what the material of the shawl does. So that is how I am using the shawl as an example, and by the end of this presentation, you will see how I'm using this example of the community on the fringe to describe what I have gathered from my data, from my study, which took place on an acute psychiatric unit in a hospital. I'm not going to mention the hospital name or anybody who participated in my study, because they signed an informed consent in which I promised to maintain confidentiality. With that, what I've done is basically call it the Mountain Hospital. So some of you may already know about it because I did talk about it in class prior to this. But okay, so did I leave anything out? So it's part of the shawl's material. It separates. Colors and textures may vary in these separations, and yet it still stays attached to the shawl. So keep that in mind as we go through these different slides. So when I come back to it at the end, you can let me know whether that also conveys a message to you that I intended. Okay, so applications of the community on the fringe metaphor in this study. The relation of patients with mental illness and substance use disorder, MISUD, is how I refer to it in the slides, to the behavioral health unit of Mountain Hospital. I also look at the relationship of the behavioral health unit to the hospital as a whole, and the relation of the hospital to society, particularly the surrounding community, but also to some of the health problems related to addiction in the greater population, actually globally, because addiction, of course, is a problem, and mental illness is a problem worldwide. So it really applies to a larger community. I wanted to give you a little bit about my background because I think I've kind of come into the whole research area of addiction kind of through the back door. This is sort of how I see it, because I graduated from college and went to New York immediately because, and that was in the latter half of the 60s, so probably nobody here is old enough to remember that, but I remember it well. And there was a lot going on, and New York City was where everything was happening. And I wanted to be there, and I lived in Greenwich Village, where even more was happening. And of course, there was the civil rights movement. There were women's consciousness raising groups. There were protests against the Vietnam War. There were lots of drugs being introduced that were being used for recreation. And so there was a lot going on. Of course, I was in the profession of nursing, and I was also a graduate student. So I was kind of on the fringe, if I can keep from overusing that metaphor, of all of these happenings, but I was very much aware of it. And then flash ahead about 25 years to when I started my doctoral program, and we were asked to do, after completing all of our coursework, we were asked to write up a conceptual analysis that we had to do an oral defense on. And what I chose was a very simple topic called consciousness. Okay, and I will tell you that the chair of this committee that was for this oral defense said, you have picked a very complex concept to discuss. But of course, that never was any obstacle for me, because I just jumped right in, and being clueless about the nature of it, and found out, oh yes, it is very complex, and the more I can learn about it, the more I liked it. And of course, I always had to remind myself, after I completed this oral defense, that when I actually write the dissertation, I am writing it for nurses and the development of the knowledge in the field of nursing. So I started looking at altered states of consciousness as my area of, for my dissertation, and I did a philosophical inquiry about the phenomenology, which is the subjective experience of addiction as written by authors and famous people, and was looking at how it could relate to a philosophical stance written by William James, who was a psychologist and also a philosopher. So I was biting off a lot more than I could chew, but I was fascinated by the whole area. So that's probably how some of you students might feel in terms of the field you've chosen, that, whoa, I had no idea this was so much. But it all worked out in the end. I got my PhD, and I learned a lot, mainly about myself in the process. I think that's true of any education, though. So then jump ahead to 2010. I'm kind of highlighting the major things that have influenced how I approach this particular study. And in 2010, I was lucky enough, fortunate enough, to be granted a sabbatical, and I went to France to study French nurses' perspectives on addiction. And I was very interested in going to France, first of all, and then, of course, I was very interested in meeting French nurses and finding out how they go about taking care of individuals with addiction problems in their community. So I was in a small community in southern France, and I had interviews with the nurses, and then since I was immersed in it, I was there for a whole semester, I learned a lot about the culture. Not everything, but some really important concepts, some of which pop up again in the results of this study. So that's how I got into ethnography, because I wanted to look at that cultural interaction with what nurses do. And I loved it. Of course, I had the difficulties of not being very fluent in French. In fact, I would say minimally fluent in French. But I conducted interviews in French, and I learned quickly. And then I had some help in transcribing them. They were all audio taped, I'm happy to say, so that I got some help when I returned to the States to transcribe them and into English. So then I could interpret them. Okay, and then, so I wanted to go on. I wanted to do another ethnography about nurses' perspectives, but I wanted to do it this time in the United States. So actually, I started this study in terms of preparing for it in 2014. And first, I had to get entree into a hospital that would allow me to do my research there. And then I had to follow the submission process, et cetera, which I'll go into at a little bit more depth. Okay, so the reason I give you this background on myself and my interests and kind of the path I've taken to get where I am today is, well, I'm in retirement, so I guess that's a good place to be. But particularly in terms of my love of research and developing knowledge, is that it's critical for a researcher of a qualitative method to have a lot of knowledge about themselves and what kind of biases they have that might influence the outcome of a study. So the more I can know about myself and how I got to where I am today, the more I can kind of put that aside when I'm interpreting what the people, the nurses and other healthcare personnel that I interviewed, what they're telling me. So I have to, what we call bracket, B-R-A-C-K-E-T, I have to bracket that information and put it aside. Okay, so that's part of the methodology of ethnography. I actually, when I was doing this study, I kept a separate journal, which I called my bracketing journal, because I was writing down all my responses. And it's interesting how much of what was going on in my life was also written in that, because it was influencing me at the time. So it's kind of a fun thing to look through at this point in time. And I'm saying, I can't believe I responded like that. Okay, so so another very important element in my study was what are the trends in society that affect research and affect what I am particularly interested in, which is addiction and mental illness, both of which are highly stigmatized in our society, and both of which have how am I going to put this, adverse responses of patients and to their context and people around them. And this also happens in the mental health unit as well. Okay, so there's an escalation of substance use and abuse, morbidity and mortality rates. I know on PBS, I keep seeing ads for battling opioids.com. There are a lot of initiatives that communities are embarking upon in order to control opioids because people are dying, and particularly our young adults are dying, and everybody's important, but our young adults, of course, are the future of our country, so that's particularly meaningful, and it's everywhere. As my son, I was telling him about something that was on Frontline last night about Dayton, Ohio, and the effect of opioids there related to industry moving out of the city and the city basically collapsing. And I was thinking, I was telling my son about this, and he said, "Mom, that's true all over the country." So it's affecting really every community. And the simultaneous treatment of mental illness and substance use disorders, which is another trend, and that is related to theories in psychology and psychiatry that have indicated from research that the treatment is better if it's done together. Now, this is something new because previously substance abuse was treated as one part of it, the picture, and mental illness was treated as another part of the picture. So they were treated separately, but they found it's not as effective as treating them simultaneously. Okay, so, and then of course we have our insurance companies, health insurance companies, that mandate that in order for hospitalization to be paid for, that you need to have both mental illness and along with that substance use disorder. So you can't just be admitted to the hospital with a diagnosis of substance use disorder. Okay, substance use disorder is the latest terminal, sort of umbrella term for addictions of all kinds. I'm particularly interested in drug addictions, but that came out in 2013, that label. So that's what I use. Okay. Any questions from anybody so far? Okay. This is a busy slide, and so you won't be tested on this. You'll be happy to know. And but I wanted to tell you, particularly students, those of you who've had research know how important the literature review is to support your research question and guide the research study. But so I just picked out some of the extensive studies since I've been doing this for almost 20 years. I have a lot of information, but I picked out the ones that are most pertinent to this study, and those are the ones by anthropologists, sociologists, who, of course, are the ones who originated ethnography as a research methodology, to my understanding. And they consist of May and Kelly, that's starting back in 1982, and there are certain important elements of these studies that I will be talking about that are very germane to my study. And then there are philosophers. Michel Foucault wrote a book called Madness and Civilization, and he traces mental illness through since the Middle Ages and how society viewed it and how that view of society influenced how the mentally ill were treated. So originally in the Middle Ages, they were part of the community. They wandered around. They had their quirks and their idiosyncrasies and their moments of madness, but they were part of the communities. And then later on, in the 16th and 17th centuries, they moved into institutions, and that was because of what was going on in society as well. So it's all very much interrelated. So that was William James. I do have to mention because he was my mentor for my dissertation, even though he died in 1910. But he was part of my dissertation, so his works have been very influential in terms of my studies and my outcomes. And then we have various nurses who have done research either in ethnography or looking at particular aspects in the psychiatric unit that are important. The key elements, studies that were important to my research in terms of the practice of nursing in acute care environments, psychiatric environments, focused on risk assessment and management, communication and documentation, dispositions of patients, and teamwork. And there's some interesting quotes that I wanted to mention from the nursing studies, if I can just remember where I put them. That were important to me and came back to be a part of my understanding of the outcomes of this study. One was anthropology, which is as I mentioned, the origin of ethnography, is a field that celebrates complexity and ambiguity in a world looking for simplicity and clarity. And those are certainly my feelings and thoughts at this point in time, after having worked on this study for 4 years at this point in time. And I'm sure it will continue. So I wanted to mention that one. And let's see, what were the other ones? The nursing studies that I like particularly because I'm a nurse first, teacher second, nurse first. Let's see. This one is by Deacon and Cleary in 2013. And it's about teamwork in nursing, that nurses have to be give continual attention to teamwork because they are dependent on one another, and all the healthcare professionals that work on an acute care psychiatric unit have to work as a team constantly and be there, as one of the persons I interviewed said, we have to have each other's back because there is the risk of people behavior getting out of control. And let's see. They had to be cognizant of what their colleagues and patients were doing simultaneously and be prepared to drop or adapt their activity if something more pressing demanded attention. They have shared responsibility for care of the total ward and all the patients, no matter to which patient they're assigned. Okay, so some of these I will come back to later as well, but I just wanted to mention those. Okay, so enough of this. You will not be tested on all of these. You'll be happy to hear. Okay, so I arrived at my research question, and as Dr. Perangeli mentioned, this is a work in process. I keep trying to make it shorter, but it doesn't seem like I have been able to accomplish that yet and include what needs to be said. So what are nursing perspectives emergent in the culture of an acute care psychiatric unit related to the care of patients with mental illness and a co-occurring substance use disorder? So you all know now that from the title and the research question. The aims were to deepen knowledge related to psychiatric nurses' response to the patients they're caring for with co-occurring mental illness and substance use. That makes sense if I'm looking at their perspectives. To examine the current culture of one acute care psychiatric unit, and to describe the interacting effects of professional perspectives and culture on care of this population in this setting. Okay, my design, as I've mentioned more than once, is a focused ethnography, and it's an emergent qualitative approach to the study of the dynamics of a culture and from the insider view of those who live and work in that environment, and from the outside view of the scientific researcher. There are terms for that. Emic is the inside view and that is used, and etic is the outside view. Focused, it narrows the culture to a particular healthcare setting, one acute care psychiatric unit. My first exposure to ethnography was Margaret Mead's study of Samoans. I think it was coming of age in Samoa. It was an island. I think it's in the South Pacific. I should know this, but I don't remember. It's been too long. Do you know, Jim? I see you nodding. Yeah, okay. And she was there for years. And then she reported on what it was like to come of age for adolescents in that particular culture, and how all of the cultural traditions and values influenced how that was perceived, and what kind of rituals initiated young people into the community as they went through adolescence. But mine was not that long, 2 years. Hers was much longer. I think hers was about 5 years, maybe more. It's been a long time since I actually read it. Okay, so these are the data sources that I collected for that are ethnographic methods traditionally. One is participant observation. And so I began my study by spending a month just observing. I would just go on the units 2 or 3 days a week and spend 2 to 4 hours just walking around and observing. And as I was there longer, I began to participate in small things. I would answer the phone if it rang and nobody was in the nurse's station and I was there. I would attend the multidisciplinary groups that were held in the morning and add any observations that might contribute to added information about patients if it wasn't interfering with the discussions that were going on. And if there was a sentinel event, which is kind of crisis situation, when a patient is out of control, there were a couple while I was there, I would assist in getting the other patients in a safe place and, recording some information that could be used by the nurses when they do their documentation. So I also talked to patients, although I did not interview any patients. That was not part of my research. I talked to them and I explained to them, if I was attending a group, why I was there, the purpose of my research. I would give them an explanation. They didn't seem too interested in my research, but that was okay, right? But they didn't object to me being there, which was nice. And then archival retrieval, which in the case of this unit, I was looking at charts, I was looking at nursing documentation, I was looking at the forms, I was looking at documentation by the interdisciplinary team, and particularly by the drug and alcohol counselors that would hold groups 4 days a week on the unit. And then they would have certain forms, wellness forms and safety forms that the patients would fill out with the nurse when they were ready to be discharged. So I was accumulating all that data in addition to the history of the unit and the history of the hospital and of the community itself. So I was gathering a lot of other data that was summarized under archival. I mentioned some of these, the informed consent. First of all, after I gained entrance to the hospital to conduct a study there, I had to develop my proposal and send it to an institutional review board. and this particular hospital didn't have their own, but they had an external IRB that was in another part of the country, so I sent it to them, and then their committee reviewed the proposal and approved it, and then I had to send it also to ESU's Institutional Review Board, and once it was approved by the external IRB for the hospital, then East Stroudsburg University also approved it. So there were two bodies that were looking at the proposal, and of course, this was to ensure this protection of any participants in my study, that their confidentiality wouldn't be violated. I had to make sure in my informed consent that I explained the research, any benefits or risks entailed by the study, and that they could withdraw at any time without penalty, without their job being affected, and that I would respect their confidentiality at all times and keep all of the information. I was the only researcher involved, so I kept it in my password locked computer, and we'll keep it. East Stroudsburg, I think, requires 7 years. No, it's 3 years that that information has to be kept. Process consent is necessary in qualitative studies where interviews are being conducted, because sometimes sensitive material comes up during the interview that the individual may be uncomfortable with. So here is where the researcher's skills are very important, and the perceptions of the individual being interviewed, that they are uncomfortable with what is being discussed or even what they're saying. So then I would stop and say, would you like me to continue with the audio tape? Because this is all being recorded. Sometimes an individual would say, please stop the audio tape for a while till they could come up with a response that they felt comfortable telling me about, and that was okay. So I was very much aware of this. Possibly, I mean, this is why nurses make good researchers, all bias aside, because they are constantly attuned to other individuals' responses and how to modify their own based on that, but always for the aim of protecting your participants. Okay, my sample, I used purposive, so I selected people who were nurses and those who were healthcare professionals on this specific unit, both present and previous. And snowball sampling methods is when one person you are interviewing or even having a more casual conversation with might suggest, oh, you've got to talk to this person because they really know what was going on in this unit at that particular time. So that was very helpful to me in making sure to include these individuals in my sample when it was possible. So my inclusion criteria was that they were employed for 1 year at least or more on this unit, English speaking, not French. So I really could make it much easier for my transcription and interpretation. And they had the appropriate degree and licensure or certification for their role. I interviewed 20 key participants, 15 RNs, 4 ancillary healthcare professionals, the psychiatrist, the 2 psychologists, and caseworkers, 1 caseworker, and 1 former retired secretary who'd been on the unit, this particular acute care unit, for I think maybe 35 years since it had started. So she definitely was a repository of much information, some of which I couldn't verify, but it was her point of view. Interviews are, you're getting the subjective point of view. Okay, so 16 female and 4 males, which was interesting because when I was doing my interviews in France, all of my interviewed nurses were men except 2 women. So it was a kind of an interesting change. Okay. Data collection, as I said before, was 2 years from October 2015 to October 2017. Participant observation went on for that period of time, 11-15 to 11-17, and that was by the time I got all the IRB proposals back. It was already into November. Audio tape interviews went from January 2016 to September 2000. Yeah, right, it was 1 year, 1 year, yeah, right. I'm saying that doesn't make sense, it was a 2-year study. Yeah, so I did all the interviews the first year. And the reason I did that is because I wanted to make sure that I got a chance to transcribe, analyze, and interpret them and get back to those who were interviewed with the categories or themes that I came up with based on my analysis and interpretation. And that is called member check in qualitative studies, for those of you who aren't aware of that. So they could give me their input on those particular themes. And then my archival retrieval was continuous with the major focus the second year. Okay, so these are the methods I used for analysis and synthesis. Constant comparison is used in several qualitative studies, both grounded theory and ethnography. And it really means basically that as you're collecting the data, you're comparing it to what you've collected before. So you're always going back and forth to from newly collected data to data you've collected previously. And theoretical and thematic coding is when you your interpretations, you're looking for major categories, and it begins sort of globally where you have a lot of different categories, and then you eventually, based on your interpretations and the gathering of more data, you start to narrow the number of themes. So that's the thematic coding. And of course, I completed several, I'd say 3 research journals, writing my observations, and then my bracketing journal, of course, was my responses so that I could make sure to separate the two, and then the archival retrieval, reading books on the history of the hospital and even the history of ESU, because they were next to, sorry, that's too revealing. I shouldn't go there. Catch me if I drift off. Okay, so triangulation of data, I brought together those all 3, and that the purpose of the 3 different data sources is to ensure scientific rigor and that you have adequate amount of information in order to make your analysis. Okay, and these are my findings. I came up with cultural themes and nursing perspective themes. The cultural perspective themes had 2 sub-themes, cultural boundaries and cultural ambience. And the nursing perspective themes had 3 subcategories: pain management, control, and ambivalence. So looking first at the cultural themes, I looked at the history of the community hospital, which in itself is very interesting. The history and physical structure of the mental health unit. It was originally called a mental health unit when it was first founded in first opened in 1968, and in the 80s it changed to a behavioral health unit. And social changes of the surrounding community. So it was a semi-rural community that eventually over the 20th century became more populated. Community development spread out into the surrounding community, and they finished the interstates, so that meant that access to major metropolitan areas was possible, and also it allowed for drug trade also to enter into the community more easily. And social changes in the community hospital and behavioral health unit. The location, of course, it was near the interstates when they were done. There was a growth in leisure and recreation activities, and there was the evolution of substance use disorder in the community and psych unit populations. And I was particularly aware of this when I was sitting in on the drug and alcohol groups, because every time I was there, there were more patients, until there was actually one day where all the patients were in the drug and alcohol group. And that was not because that all of them had been diagnosed with mental illness and a substance use disorder, but it was because some of the patients who only had a mental illness diagnosed, the nurses thought they could benefit by the kind of insights and education that were communicated in the drug and alcohol groups, which met every day of the week. Only one day they had also had Alcoholics Anonymous or Narcotics Anonymous instead of the drug and alcohol groups. Culture, and I'm just giving you an overview here. Cultural ambience, that's the living experience, the feel of the unit, which would be the mood, and how space is set up. And thanks to one of my colleagues, Professor Lynn, drawing a blank on your name because your last name, Lynn Kopp, yes. How could I forget? Sorry, Lynn. I drew this one, which is small, and you probably can't see it. And this one on the my left is a larger one that Professor Kopp drew. So I'm grateful for her doing that. But the point I wanted to make in terms of the physical structure is where the placement, first of all, of the healthcare professionals. And there's an outer unit and an inner unit. The outer unit leads to the elevators and the stairs, and it is locked. And you can only get in by pushing a buzzer, and there's a camera out by the elevators so that the staff can see who you are and you can be buzzed in. Or staff who work on the unit have an ID badge, which is swiped in order to open the doors. So in order to get into I guess I'll put this outside locked unit, you would come in through the doors here on the left. And then from there, you go into the inner unit. There's a door here and a door here. This is the inner unit. The psychiatrist's office is in the outer locked unit. The psychiatric counselor is in the outer locked unit. The caseworkers are in the outer locked unit. And the manager and the secretary are on this side of the corridor that leads into it, and there's also a bathroom there. And this is a multidisciplined room where art therapy is conducted, interdisciplinary groups are conducted. So you can see the picture. Now when you get into the inner space, this is the inner unit. It is also locked, both at here and here, which are the entrance ways, and then here with the exit is on this side of the unit, at the end of the unit. And the important thing I wanted to point out in space is that it's small. It feels cramped when there are 21 patients in there. And some of the senses of smell are bland, basically, other than when meals are being served, because the mental health technicians and nurses both help patients who need help with hygiene if necessary. And so there's very little incontinence, as you see on other units of bladder and bowel. So the smells are really not offensive in any way, and they're almost non-noticeable, I would say. But some of the respondents said that it feels like there's no circulating air, and it's stuffy, and the air feels stale. So I thought those were interesting because these are interviewed persons are there for 8-hour days. And so they can go home and go out in the fresh air, but the patients are there continuously. So that's just something in terms of the sensory impressions, in terms of smell and that kinesthetic feel. The mood. That would be the mood. Subdued, structured, respectful. There are the sentinel events, which is when the patients become out of control. Those are the only exceptions. But the general feel of the unit is quiet and subdued. Okay, the point I wanted to make about movement is that patients can walk around the unit, this inner unit. So here's the direction of it. Doesn't show up here. There's a hallway here where this, in front of the nurse's station. The nurse's station, we really could put a heart there because that is the heart of the unit, the nurse's station. This is my version of a heart. Because not only nurses are doing their documented work there are also social conversations going on between nurses and patients and nurses and other healthcare personnel. And it's a semicircular unit. Just in 2016, they erected a plexiglass barricade on the counter in that horseshoe-shaped nurses' station to maintain confidentiality of conversations, which of course is very important in the healthcare setting, but it doesn't, according to nurses I talked to later, it muffles it a little bit, but it doesn't really prevent it. And I mean, patients can see the nurses and they can get their attention. There are openings in this plexiglass barricade so that they can open a window and talk to them directly or put the telephone out so that they can call somebody. But it's very important because you see patients kind of hanging around there and they walk around that area. I think you can see better over here. I don't know if you can even see this, but here's the nurse's station. They can walk all the way around. And some patients, particularly when they're very agitated, they spend a lot of time walking around. So that's, you see a lot of movement in that. But the nurses go out to give medications and to talk with patients. That usually happens in the either in the kitchen area, which is on the right side there, or in the dining room area. They'll sit down at one of the tables to have a one-on-one conversation with patients. So the sense of time, of course, from the patient's... Oh, yeah.
How many bedrooms are there? Because you only have 2 up there, but I just wanted to get a sense of like how many patients.
Oh, right. There are actually, yeah, you can see it on this one. There are 21 patients, and there used to be 22, but they added another seclusion room. They have 2 seclusion rooms now, where before they only had 1, and so there can only be 1 patient in a seclusion room. And that was added because they have more need for patients to be on a one-to-one observation. And some of them can be in these seclusion rooms for a while. They have to be monitored every 15 minutes. In fact, all patients have to be monitored every 15 minutes, and that's one of the things that mental health technicians do, is go around into patients' rooms, do checks for any kind of contraband that might be in the rooms, such as drugs or other kinds of things that might hurt people or hurt the patient, or might be drugs, or I mentioned that, or food. They're not allowed to have food in their rooms. So the rules have become stricter and stricter. Any other questions? Did I answer your question, Stephanie? Okay, this is a little bit about the history. It's just a brief slide, but it started out, and this is there are 2 boroughs that are next to each other, and the county hospital started in one borough, and that was to serve patients who could pay, and the general hospital started in the other borough, and that was for the medically indigent who could not afford to pay. And they eventually joined together in 1931 and became just the general hospital in one of the boroughs. And that name changed to the Mountain Hospital to convey the location of the hospital and the community that it served. It was a more global term, more global in one way because it was directed toward the whole community rather than just one of the boroughs. So it took in a larger population. And then the Mountain Hospital changed to the Mountain Hospital Center because more services were being provided, more additions were being added on to the hospital, and so they wanted to make sure that they met all of the healthcare needs. And of course, healthcare was becoming more specialized. There was more technology. So there was a lot going on in the general community that was impacting the hospital itself and in the direction of their growth. They also decided to use the corporate model that had been so successful in other businesses to influence how the economics of the hospital worked. So they used a corporate model. That meant that essentially profit, even though it was a nonprofit hospital, that they needed to make enough money to be able to grow it to serve the healthcare needs. So those were all factors there. And then eventually, and this only happened more recently, the Mountain Health Center became a part of a regional network. And this Mountain Hospital name joined with the regional network. And again, looking to increase services, but the change in the size and complexity of it, but also this acute care setting in the community hospital was the hub of the county in terms of health care, and now it has moved to becoming a fringe status as a satellite. So that's been a major change in terms of how individuals who work in this hospital see the hospital and their experiences and the effect on their profession. So it's still in, these transitions take a long time. So what the outcomes hopefully will be a positive direction in terms of providing services to the community as well as other people in the county, but that's yet to be seen. It's in a transition period at this point in time. So I think it's a very interesting, sort of like ESU, growing, and having a lot of growing pains in the process. Okay. Social changes in terms of the history, it started, interestingly enough, from a federal grant to serve the 3 counties in the area, and that was applied for by the chief psychiatrist. And when it opened, it was actually in a semi-autonomous position from the hospital because it was owned by the grant from the federal government. And it was eventually purchased by the hospital after several years, which brought changes to that. The mental health unit, it was called the mental health unit at the time, the director reported to the vice president, which again gave the unit more autonomy than it had later when it reported to nursing, which happened in the 80s. Originally, the unit consisted of the 4th floor, which psychological counseling was going on there, psychotherapy, psychological testing was done, rehabilitation therapies, drug and alcohol rehab, a methadone clinic, which is a substitution for opioids, and currently in the 1980s, it closed because of changes in funding. Everything prior to that was fee for service, so every service is provided, a different fee was charged, and the insurance or the patient would pay it. But in the 1983, I believe, the DRGs came in, diagnosis-related groups, so that the hospital then would be paid in a lump sum for all the services. So it became too expensive to run this 4th floor. I'm sure there were other factors that were involved as well. And the 6th floor, which is still open, is the current inpatient treatment, and that's all that's offered. They do offer the drug and alcohol as part of their services because of the increase in numbers of patients coming in with addiction problems in addition to mental illness. In the original 60s, late 60s and 70s and early 80s, milieu therapy was the treatment approach. And of course, it was a method of psychotherapy that controls the environment in order to provide positive relationships, positive role modeling, teaching the patients how to achieve that in their own life situations. And that continues today, but then they added the behavioral therapy, which was based on the idea that individuals who have mental illness or substance use disorders their behavior is influenced by the conditions in which they live. So it kind of builds on the milieu therapy, but it's much more directed just to the behavior, changing the behavior, so people can manage their lives better when they get out of the hospital. And we talked a little bit about the physical structure, but at that time, the mental health unit changed to being called the behavioral health unit, which was a reflection of the changes in theoretical approaches to psychotherapy. Whoops, wait a minute, where are we? Okay, the ambience. Let's see, I also talked about space, time, perception. The general feeling of this unit, from my observations, is that it's slow. The pace is slow compared to medical units. It's the everything is very well organized and structured and moves from one activity to the next, but there's no rush. So if patients are going to a group, whether it be a drug and alcohol group or a community group, the mental health technicians and nurses round up the patients, but it's always with respect and without a feeling of, you've got to do this now, demanding, at least in terms of my observations and from what staff has told me. But it's interesting when they're going to a group that's outside the inner locked unit, and it's in the multi-purpose room, which is in the outer locked unit at the end of this hallway when you first walk in, right here. They're lined up in the hall. And anybody have any thoughts about what you've seen people lining up for in a hallway? Does that bring back any memories to anybody? Well, the first time I saw it, I was reminded of elementary school, how we had to line up in order to go to the gym, to go to the bathroom, to anything you wanted to do outside of the classroom. Everybody lined up, and you had to stay next to the wall in the hallway. And of course, that was a long time ago. I'm sure things have changed. I don't know if they still do that. They do? Okay. Okay. So you can attest to that. But that's sort of what, which some patients were reluctant to do this, and depending on where they were in their illness. But it all eventually happened. But it was just an interesting observation in terms of the feel of the unit and the activities and what patients are being asked to do. But it also, there was no feeling of rush, and it had to be done this minute, like somebody was going to, that you get sometimes on a medical surgical unit, that somebody's going to die if we don't do this right away. So there wasn't that sense of urgency. I missed theme. I'm pushing the wrong buttons. Themes. Pain management. Okay, so these are the nursing perspectives, themes from the nursing perspectives. How are we doing time-wise? 15 minutes. Okay, all right, so I better move along here. Okay, so there are three major areas that came out of interpreting all of the interviews. And I included nursing perspectives and the perspectives of the other healthcare providers. Thanks for coming. Yeah. Professor Mendoza, just leaving. Thank you. Pain management, control issues, and control issues had three subheadings: safety and vigilance, discipline, and poverty of resources. and ambivalence. And that, I looked particularly at the idea about true mental illness, and this was in comparison to patients who had mental illness and a substance use disorder. So there was some questioning about, and you'll see this when I give you some of the quotes to support, quotes from the interviews to support these categories or themes that were identified. And mental illness as a crutch or an addiction strategy. So these were two interesting examples of ambivalence of the interviewed individuals. Okay, pain management. I think they are hurting, meaning emotional pain and suffering. I think they are hurting horrible. The pains in them are greater than any other patient. So they're talking specifically about patients with mental illness and substance use disorders. And another interviewed person said, I think it has something to do with the pain scale, which as a nurse I was particularly interested in this response. We are so eager to treat pain completely and totally eliminate pain. And the next interviewed person said, nobody is ever allowed to be in pain. When did that happen exactly? Some things hurt. We admit them, and the amount of pain meds, meaning they admit the patients, and the amount of pain meds that are prescribed is mind-boggling. So it seems to be increasing in terms of the amount of pain medication that is given to these patients who already have a substance use disorder. But as all of you nursing students know, pain is subjective. So it is the patient's perception of pain that is being communicated. And somebody outside, 10 more minutes, okay, I've got to move on, okay. So I'm going to move on, give you food for thought here. Okay, control issues. And the first one was safety. This is a sub-theme. Most important aspect of nurses' role is safety. Make sure that nothing bad or something bad doesn't happen. So this is a priority, which is no surprise to nursing students. Another one said, we don't have enough security. Evenings, oh my God, when you have an agitated patient and you have to worry who's going to show up from the control team, the hospital has a control team, it's scary. And they don't have any big guys on the shift like they should on a psychiatric unit. So this is very important in terms of the individual's perspective of how safe they are in their work and their ability to keep the whole unit safe if a patient who is being admitted, and of course evenings is the shift that patients are most likely to be admitted, and the greatest risk, actually day shift is the shift that patients are most likely to be discharged, which makes sense too. Okay, it's out of control. I know I'm being judgmental, but everybody has back pain. Everybody has neck pain. It's drugs, becoming crazy. It's so out of hand. So these were impressions from the nurses that things were out of hand. We have no control over what's going out there in the community, meaning the community outside the hospital. They have to go back out there. Discipline. The worst is when people never quite get it. They blame others. They don't take responsibility. That's the worst. And of course, this relates to control in terms of the patient taking responsibility for managing their own lives and using drugs, which then blinds them to their responsibility at times or is too overwhelming to take responsibility. They go through the motions when they're here. They don't believe it helps them. It's very hard not to relapse. So the importance of patients' commitment to treatment is also a perception. I still don't necessarily agree that alcoholism is a disease. It's a choice you make. So you're hearing some personal views of patients who have mental illness and substance use disorders. And I might just point out here, when we're talking about mental illness, that can be any kind of mental illness. It can be schizophrenics, it can be patients with anxiety disorders, depressive disorders. Any of those would be considered a mental ill. I mean, our mental illnesses not would be considered, but our mental illnesses. So you're getting a wide scope here, and patients who abuse drugs, mentally ill patients are more apt to abuse substances, studies have found, and they have worse outcomes when they do compared to patients who are just mentally ill and don't abuse substances. So this is a real concern in terms of their prognosis, how fast they'll get well, whether they can be independent, live independently in society. And I think the interview 6 kind of reveals that the beliefs of a lot of society about the moral stand of many people in society is that, well, you take drugs, that's a choice. It's not a true mental illness. That's where that also falls under the ambivalence part of it. And then I think it's the whole society. I don't think anybody knows how to tell the patients no any longer, but this is what I see, and it's out of control. Everyone is cross-addicted. Poverty of resources. Diagnosis of MI with substance use disorder is for insurance purposes. They show up at the hospital when they run out of money. At the end of the month, they're here. Just what good are we going to do? We waste a lot of money, you know, on their lives. It's their lives, I think, that should be sort of implied there, that it's their. And then this is a short stay unit, but these poor patients are here a very long time, months even. There's no place for them to go. There's no place for them anymore. There's nowhere to send them. Of course, as you know, or you may not know, depending on what profession you're in, that a lot of the, state hospitals are closing or have diminished the number of patients they take. So for the mentally ill, that's a real problem in terms of getting placement. And the mentally ill who have substance use disorders, of course, that is equally a problem for them. The drug and alcohol, as I said, they want them to be treated, to integrate the treatment. They wanted to make sure that they are integrated, and this becomes difficult. If there's nowhere, they don't have insurance, they're not going to be accepted because a lot of the rehab places are paid for by insurance. There are very few places they can go. 5 minutes, okay, I got to move it along. Okay, ambivalence. Because of government cutbacks in funding, we have so many patients here, in my opinion, need to be in drug and alcohol rehab. I think about which came first. I find DNA issues. Who uses drugs as an excuse? In my belief, it leads them down a slippery slope. If they are truly DNA, they are told they are bipolar. It becomes their crutch. I see patients with true mental illness, health issues. They come in because they can't afford their medications. And several interviewed persons said they preferred patients with mental illness to patients with mental illness and substance use disorders. they were more comfortable with their care. And because the substance use sometimes introduces disruptions in the units and the unit routines. As I said, the unit is very structured. So lot going on units. I question sometimes if they don't just come in and then just go out and sell it. They have a fit when they're not getting it. We give it to them because the such are allowed, and no matter how we educate them, we're still self-medicating. We're really promoting the continued use of medications. They want that because they want it for an income when they leave as well. So again, talking about management outside of the hospital as a picture in how they're seen when they're in the hospital. Now you often hear med seeking, which makes me just livid. I'm sure some of you nursing students have heard that on the medical surgical units. So patients are just want the opioid medication, which makes me just livid. Because you're in the hospital, medicine is what we do for people. When people are people are med seeking, shouldn't they be? And I think this is a dangerous situation that is happening here because we make people identify with the meds they are on. We make people rely on pills. Still, the answer isn't a pill. That's a really big problem. So there's some interesting responses based on what they found. Okay, so the limitations of this study was that my presence on the unit might have affected their responses in unknown ways. It was offset by prolonged immersion in culture, open communication, and member checks with those interviewed. Qualitative results cannot be generalized to a larger population. Nonetheless, themes might resonate in other acute psychiatric settings, provide grounds for theory development and staff education for future quantitative studies. And informants from day and evenings, I did not interview any participants. Informants is an old term that used to be used for qualitative research, but now they've changed to participants, but I slipped back into my old ways. I didn't include any night staff because of my schedule. So, but the interview nurses had also worked on nights and evenings, so some of them still do. And future research, future study of RN's perspective on specialty health units, co-occurring from substance use disorders on the maternity unit. They often have babies who are, these are other future studies. And this goes back to my original statement and the pattern of conclusions, the fringe relation to patients with mental illness, substance use disorders in the behavioral health unit, questioning whether it's a true mental illness, out of control. Patient is viewed on the behavioral health unit as a fringe element, an intrusive outsider in some cases, and relation of the behavioral health unit to the hospital, semi-autonomous originally, and semi-isolated. It's on the 6th floor of the hospital. No HCAP, which are measures of patient satisfaction. In fact, somebody said in the interviews that in the emergency room, they do patient surveys, and so the patients say, well, if you give me my pain medications, I'll give you a good response on the patient's survey. So it's sort of interesting perspective. But that's not measured on the behavioral health unit itself. So nurses on that unit don't get any acknowledgement of the work they do. And fringe status, and I said it's on the 6th floor. So it's kind of a fringe to the hospital, as that's what I saw in my observations and interviews. And the relationship to, I already mentioned this about the hospital to society, and I just wanted to add one addition, the fringe of consciousness. My research has particularly looked at the subjective experience of drugs that alter conscious awareness, and awareness that captures something beyond everyday reality is often experienced in with taking drugs that alter consciousness. So it's something to think about in terms of that fringe. So, right, Dr. Siegert is clapping. Yeah, thank you very much.